In this video, Dr. Kevin Coppelson and I go over my CBCT scan results for my maxillary expansion procedure, which remember I did before the double jaw surgery with Dr. Sam Bobek, which you can watch at the link here. I'll put it in the description as well. As usual, if you guys need help with anything CPAP, sleep study, sleep medicine, I'd be happy to talk to you. There are links in the description below. If you have any video ideas of what you would like to see that I haven't yet covered, I'm always looking through the comment section for that as well. I hope you guys enjoy this one.
Can you hear me okay?
Yeah, I can hear you. Can you hear me okay?
Do I look different? Can you tell anything? What happened?
Did you have jaw surgery?
Yeah.
Oh, nice, man. How you feeling?
Good. Yeah. I've been off the machine now for 25 days.
God
And
bless. God bless. I
sleep's
love that.
pretty damn good. I get pain still. I'm not sure if that's normal at this point. Usually only when I sleep. Like I don't know why. I think my jaw is kind of hanging or I'm opening my jaw. But yeah, it's good.
Nice. Where'd you get your surgery at?
I did with Sam Bobek. You know him?
Is the one in Seattle?
Yeah, that's right. Yeah.
Oh, nice. Cool. Hold on, I'm pulling open your x-ray right here. I'm a little sad you didn't choose me, Andrew. I'm not gonna lie.
I thought you say that. The
No.
logistics work, but I grew up right beside Seattle. It's like a
Oh,
20-minute float plane ride, so just
I
made
thought
more
we had
sense.
something special, Andrew. No,
And
I'm
we
kidding.
do. You're my maxillary expansion guy. My next maxillary expansion. Actually, you know what? That's a good question. Can you
Yeah.
do two? What if
Yeah.
I
Yeah.
came to you right now and I said, once I'm recovered, let's say in a year from now from my MMA, and I said, could I get another maxillary expansion? How would you determine that?
Um, Great question. Theoretically, yes. Theoretically, we can set up a MARPE again, um, and potentially do the surgical releases again. You're saying like after corrective jaw surgery in particular?
Yeah, in particular. Well, I guess both. So I guess there's
So
patients who'll do a maxillary expansion, maybe they're not satisfied, and then
yeah,
patients who will do a jaw surgery and then afterwards want to do a maxillary expansion. So I guess those
yeah,
are different questions.
yeah, different questions. I have a ton of experience with both. So I have a lot of people that were underexpanded and then I reassess them. Intermolar width is still insufficient. Nasal aperture is still insufficient, which we'll look at those measurements in a bit. Um, and we'll just expand them again as if they had never done it in the first time. Even though I'm sure they had some expansion to begin with, but they had room for more, and we did some more. Jaw surgery is a little bit more of a um, potential variable that I thankfully have a lot of experience with by now. So generally, I most patients can still get maxillary expansion after having corrective jaw surgery, just like you had it, as if they, never had jaw surgery. It really, first of all, depends on the type and location of the hardware they had for their Le-Fort-1 osteotomy. So, for example, if they have a plate that crosses the midline. In that case, I'm going to have to remove the hardware to do the surgery, which is fine. Um, if they have plates that don't cross the midline, I have about 10 of those. They've all turned out beautiful. I do preface all of those appointments, those consultations by telling them that, hey, there's a chance that if these, plates bend while you're expanding and they can break, and we might have to do hardware removal after the fact if you have kind of hardware failure during the expansion. But I haven't had that happen yet. So everyone kind of expanded. They have, let's say, L plate here, L plate here, L plate here. And then as they expand, the plates just follow the two hemimaxillas outwards. So yeah, so far so good. I do just give a preface warning, like, hey, if the hardware breaks, we can take it out. But I don't force patients to take it out prophylactically because I've had a few cases now, like 10 cases, where they all expanded and nothing went wrong. But it's better to have that conversation as a possibility beforehand because I'm sure eventually one of them can break during the expansion, and hardware removal is not the end of the world, but just something to like talk about beforehand.
Interesting. Mm.
So
Yeah, how did
I
you remember my case? What did we do? Does it tell us how many millimeters we expanded?
yeah,
I feel like you and I shared a sentiment of we both kind of wanted to keep pushing it, but the ortho was like,
The ortho said no. Yeah.
Yeah, the ortho is like, I had a question about that too. Where are things with that? Do all the OMFSs who are doing maxillary expansion, but also of course yourself, do you guys always just yield to what the ortho says, or have you guys started to understand how far
Uh,
you can push it
I,
more?
yeah, I would say, I don't know what other people do. Um, I generally try to work in conjunction with the orthodontist because my side of things is kind of like one variable, and they have their own variables that they're looking at in terms of where they think they can get your bite. And I don't believe in like fixing one problem by causing another problem. You could put people in weird bites, like Brody bites, where they don't have a normal posterior contact on each side. That being said, I'm doing a lot of mandibular transverse expansion now, so we're able to, in those cases where let's say someone has a little bit more of a conservative orthodontist, we're like, okay, what if we do some mandibular expansion so we can push the maxillary expansion to where we want to get it to? So that's exciting. You look good, by the way. You look great. Surgery turned out awesome. You look
Yeah,
amazing.
thank you. I think I'm still swollen here
Still a
and
little puffy, but that's
yeah.
normal.
Yeah, can you tell me anything about what I should expect at this point in time?
How far out are you?
I did it on the second, so we're 25 days later. The thing that's really unclear, I've tried to really scour for this on the internet. There's some good studies on how much edema there should be, and there's a lot of just huge mixed bag on just anecdotal evidence of patients reporting how well they sleep at this point. Some patients are reporting it takes some months. Some patients say they feel it right away.
Yeah.
Um,
Uh, I
I,
would say I would say most patients notice at least some improvement night one, um, minus the swelling, the pain, the congestion, which is not fun, as you probably remember from those first couple nights.
yeah,
Some patients are, I would say, hyper responders, and night one is like, dude, I know I'm cured, kind of, like
yeah.
they a lot right away. Um, I would say a month is like a good time frame where most people you kind of know what you're got out of the surgery. Because like what you're talking about for swelling and stuff, excuse me, usually um, by night one you have excuse me, by week three, 80 to 90% of the swelling is gone. That last 10% takes probably 6 months. The lymphatic drainage of the face changes because the surgery, and they're pretty big dissections to do these surgeries. So the lymphatic channels change, and um, so I would say usually by about a month, 90% of the swelling is gone. By then, usually you get the full how you're going to feel from the surgery in terms of sleep. And then just swelling wise, that last 10% is kind of difficult. It comes off slowly over the course of the next 6 months. So you have
So
time.
yeah, so what do you say about these patients who do like I just read one the other day, and who knows, like we're talking about the internet here on an informal forum, but there's also not really a reason to make something up when you're an anonymous user on a forum. But
Yeah.
there's people saying like, "Oh, week three, I thought it was all over, and then week three shows up and it totally turned around, and I started sleeping well."
Yeah. So, I mean, it takes like a month, I would say for
Okay.
most. Yeah. So I think that fits within the time frame, like that 1 month time frame.
And what about like the context of muscles retraining, and there's also people who may have been having lots of arousals. There seems to be some discussion around people are still kind of waking up, and that can perpetuate even though, let's say, their
Uh,
airways open. I'm not.
say that again one more time. I'm sorry. I'm aligning your CT while I'm talking to
Yeah,
you.
yeah, no worries. I was just saying there. It seems like there's some patients who although, like, I agree, if you were to look at the scans or the swelling percentage is probably not changing, but for some reason their sleep benefits are trickling in way later. And
Yeah.
what maybe that has nothing to do with the airway, maybe it has to do with tone in the airway, or maybe it has to do with the arousal system being. Can
I
we
think a
talk
lot
about?
of it is like the brain kind of resetting, you know. It's not like these patients have had sleep apnea or UARS for one day before they got the surgery. They're usually have had it for years, and you get stuck in these like neuromuscular rhythms. They call them like neuromuscular engrams, and their brain is expecting every night to not breathe well and not sleep well, right? And so it's not like for most patients, it's not like the brain is like, okay, my airway is good, I'm back to normal. It usually does take a little bit of time for the brain to reset. In my corrective jaw surgeries, I work with myofunctional therapists, and I also work with a mindfulness and meditation counselor. So all my patients work with both. And part of that is to kind of help the brain reset a little bit quicker for the changes that are about to happen. So they start with the mindfulness and meditation. This is something that's been worked out over years, so she's really good at it. But we're working on beforehand the kind of relaxation and stuff to kind of get the brain ready for the changes that are about to happen to the body, and they continue with that afterwards. I think that's a like super important part. Now, if you wait long enough, I think most people's brains will naturally reset, but I think working on it intentionally beforehand is never a bad idea. And then, you know, myofunctional therapy, I think, is also a great component of this because, you know, structurally, like my job is kind of like structurally to put things in a very ideal position, airway wise, aesthetically. Um, but function is another thing, right? And we talk about so like I can fix the structure, but if they have better tongue posture, they're going to utilize that airway better. And if you work on their breathing patterns, you can help them, you know, as well, right? If you like, let's start working on your breathing patterns, where you're breathing through your mouth or through your nose, and start giving them exercises and homework. And then you can boost up and get more out of the surgery that they would have got otherwise. Because everyone's going to be better when I make your airway bigger and fix the structure, but you get more out of it if you work on the function and then on top of that, um, the brain as well. And so, you know, I kind of equate it a lot to like a knee replacement surgery. So if your knee is degenerated, you know, off a cliff and you can barely walk, you will feel a lot better after getting a knee replacement. But how much better, how much more are you going to get out of that knee replacement if you do physical therapy where they work on range of motion and, you know, physical therapy to like build up the strength of your quads and whatever, you're going to get more out of that surgery. And I think that's kind of one of the missing pieces in corrective jaw surgery is, you know, ortho and structure from the surgery, and that's it. And so we've been working on this multidisciplinary kind of integrative program where we're kind of addressing myofunctional things and mindfulness and meditation to kind of get the brain and the body ready for the changes that are going to happen and get the most out of the surgery. And at the end of the day, it makes me look like a better surgeon. So I think I have any other questions in that regard?
I guess one more little one about um, when doing a second maxillary expansion, or let's just say even hypothetically a third one, isn't there some point in time with each individual patient where the bone is kind of so compromised due to surgeries that you kind of have to stop? Is that a thing, or is that not real?
I've never done three, so I'm not sure. Um, I haven't noticed an issue with two. So um, theoretically, though, let's look at it from a theoretical perspective. As long as they've had union or they achieve union at the end, there shouldn't be an issue. I think you're mainly going to be limited orthodontically by how many times you keep expanding someone. Are you putting them in a bad, you know, orthodontic position, whether that's in the upper arch or the lower arch? Because, you know, too much ortho over time, especially if it's done aggressively, can lead to like root resorption and things like that. So like I'd be concerned more like from orthodontic side of things, like taking that many hits. But in terms of the body's ability to heal, the bone's ability to heal and regenerate, I think it should be okay. No, I don't think a third time necessarily is going to cause any issues. Definitely not with two.
Okay,
Yeah.
interesting.
So this is your preoperative scan, and what I've done is I've aligned your post-operative scan to that.
So blue is pre-op,
Blue is
or
pre-op.
yeah, okay.
How many millimeters did we end up going for you? Do you
I
remember?
think like when we did the back of the envelope math, it was something like 7 millimeters, but we never really crunched the numbers properly, I think.
So this is you before, and this is you after.
Interesting.
So one of the measurements we do is like just a bone width. This is before. You're about 58.8, and then you became about 63. So just about 4 millimeter change there. Um, we can look at your intermolar width, which is how far apart the upper first molars are from each other. This is your arch before.
Hmm.
So intermolar width, we usually do it from like the mesial palatal cusp at the CEJ. So you're at 30. Became 36. So yeah, about 6 millimeters of expansion at the molars. And then the last one I like to do is something called the nasal aperture, where we measure how wide the opening into the nasal cavity is.
How much would you say people are expanding on average? If you were to take all, maybe even have that data, but what would you
Uh,
say if you took all the patients?
if I took all my patients, I would say 7 to 8 millimeters is probably the average. Um, Generally, 4 would be the lowest end, but I generally like to do minimum 5 to 6. And then, upper end, we've done like 10, 12. Someone I've done like 16 where we swapped expanders mid-expansion. So this is your nasal aperture. And we'll go through all these measurements in a bit, like as if you're a new patient, but just to see your changes. So this is how wide your nose was before, the nasal cavity opening was before. And now you're about 25. So that opened up by about 4 millimeters.
Do we have
And
any new information about turbinates and swelling? This seems to be a constant conversation. People do maxillary expansion, and then their turbinates just swell into the new space. Is that true? Is it some people?
it is true if you do not work on nasal breathing. So if you continue to mouth breathe post maxillary expansion, your turbinates will swell into that space. If you do proper nasal hygiene and focus on nasal breathing, that is consciously during the day or utilizing mouth tape at night, they should not swell into that new space. The cases I do see it in are cases where the patients have improved nasal breathing, but they're not utilizing it.
How common is it for patients to also get some turbinate reduction, like with Zaggy?
Um, Honestly, not super common in my clinic. I would say most patients, I'd say maybe like 10% of patients, he'll do some kind of like coblation of the turbinates. He does this other procedure called Vivere, which is kind of like nasal valve remodeling, which is something that is easily done in clinic, and patients respond really well to that. So some patients, they have a lot of nasal valve collapse despite having adequate nasal cavity volume. And so you expand them, they're breathing better, but they still have collapse that causes issues. And he's able to fully awake in clinic, just do the Vivere, and it's really helpful. But I would say that about 10% of patients will need one or both of those. Most patients, once you expand the nasal cavity and get them having like proper nasal hygiene and focus on nasal breathing and mouth taping, they generally function pretty incredibly. And it's rare to see any swelling of the turbinates into that space if they do all of that. So yeah, so your nasal cavity expanded by about 5 millimeters. So this is called the nasal aperture, the piriform aperture. You went from like 21 to almost 25. The normal range is 23.5 or more. Intermolar width generally. Ideal is 38 to 42. I think you went from 31 to 36. So almost at the ideal range, not
So you're
quite.
saying we got to do another mind.
I think we gotta do another um,
Hey,
but
I wouldn't be against it, but we'll see what happens with this first. I feel pretty
no,
good, but
yeah, no, I'm not. I'm actually joking. We'll see how you do. I hope you don't need anything else. I hope you're cured from all of this. So let's pull up in your original scan, and I'll kind of take you through my. Obviously, I do a clinical exam, but CT for transverse, what I look at. Sounds good?
yeah.
So I'm opening your 2023 X-ray. So this is your 2023 X-ray. One of the things I just like to do is just to straighten things out. People usually have like tilted heads and stuff when they take these scans. So I just like to align things a little bit. Chin up, very common in patients with sleep disordered breathing. So I'm going to put your chin down just for
Looks horrible, eh? Look at that mouth.
look at that low resting tongue posture.
The
Never very.
airway.
Yeah. Oh, did I close the other one? Oh, I should have showed you your airway before and after. I'll open it back up in a bit. Okay,
Okay.
so we'll look at your airway. Obviously, your tongue is really down and back here. Maybe it looks like you're biting on a bite stick, which kind of forces the tongue back. So this is probably an artificially small airway, but this is called the posterior airway space or the pharyngeal airway space, basically the airway behind the upper and lower jaw. People like you that had sleep apnea, this is the part of the airway that obstructs. It's called obstructive sleep apnea because the upper airway obstructs, doesn't allow you to ventilate normally, oxygen drops, sleep architecture gets disrupted, and all that stuff. So this is the posterior airway space. This is a 3D rendering of your posterior airway space. Again, yours is artificially small because your tongue is kind of down and back. Looks like you were biting on a bite stick, which
Yeah.
we published on CBCT protocols, Dr. Zaghi and I, and we came up with the stuff you should and should not do when you're taking a CT scan to not have poor airway readings. But this is yours. So let's
Yeah.
say back, minimum cross-sectional area is 40 millimeters squared. So you can see it's kind of color coded. And you can see people get in the red when they hit 150 millimeters squared or below. And that is where the research kind of does align that people below 150 millimeters squared will generally have about a 3 to 7 fold increased chance of having or developing sleep apnea at some point in their life. So this is a good clue. Obviously, the airway is a dynamic structure, and a CT scan is a snapshot of a dynamic structure, but it can be very, very, very helpful. But theoretically, to be fully accurate, you need multiple scans and kind of take the average of all of them. But assuming you follow Dr. Zaghianak's protocol, you're probably going to get a good scan the first time because we talk about like have the patient swallow, don't use a bite, try to avoid a chin rest. Having the patient have a horizontal gaze and things like that so that they're not chin up or chin down because that can also affect the minimum cross-sectional area of the airway. It's an open access article, so just search Zaghi Coppelson. It was in the Journal of Oral and Maxillofacial Surgery, I think last year. But anyway, so this 3D airway is a big clue. In the old days, we used to look at two-dimensional airway measurements. Some people do not have this option on their CT, and all they'll have is a two-dimensional view of the airway. And so on a two-dimensional view, we do what's called a posterior airway space measurement, which is the length of the airway. And so you'll measure at different areas. What is the length of the airway behind the tongue, behind the palate? And two-dimensionally, the research shows that you don't want to have an airway less than 11 millimeters long at any place. So you can see you're at 7.5,
Yeah.
6.5, 5.0. But if your software has the 3D measurement, this is a little bit better. And the software will usually give you a total volume and a minimum cross-sectional area. Total volume I do not like because let's say one time I start the airway here, the next time I start it here, you're going to get a different volumetric measurement of how big the airway is. But the minimum cross-sectional area just kind of goes slice by slice through the airway, and it measures the area at each slice, kind of like the square footage of a room, but you're measuring in square millimeters. And it's looking for where is there a bottlenecking and how bad does that bottlenecking get. So that'll be consistent between 2, 3 scans versus a volume, which will kind of depend on where you start and stop it. All right, so measuring someone's transverse dimension, which is how wide their maxilla is, there's a few different measurements to do. I like to use the UPenn CBCT analysis first, which you go to the first molars and you measure the width of the maxilla at the first molars. Now you're measuring a skeletal measurement, so you're kind of looking at the most concave portion of the maxilla. The reason you pick this is because this is the skeletal base width. All of this part of the maxilla that is housing the teeth is actually one of the four processes that come off the maxilla. It's called the alveolar process. And for example, if there's a denture patient, you pulled all their teeth, their maxilla would resorb away to about here. So this is kind of like the true skeletal base of the maxillary bone itself. You don't, the teeth are coming, it's a process that comes off the maxilla. So you measure the skeletal base width of the maxilla. You're looking again, most concave at the first molar. You're measuring 59 millimeters. You do the same thing at the mandible. So you come to the first molar of the mandible. You see where the furcation is of the roots. That's where your skeletal base of the mandible is at the first molar. So the furcation is where the roots split. You come right outside of that and you measure the width of the bone from furcation to furcation. So you're 57.6 on the bottom, you're 57 on top. Normally, the maxilla should be 5 millimeters skeletally wider than the mandible. Why is that?
I think it's 60 on top, is it?
Oh, 60. Okay. So you're 57.6. Let's round up to 58 and 60 on top. Okay, let's say 57.5 and 59.5. So right now your maxilla is 2 millimeters wider than your mandible, right? So normally the maxilla should be 5 millimeters wider than the mandible. Why is that? Because if you have a normal occlusion, your upper teeth should sit 2.5 millimeters outside of your lower teeth on each side. We call that a posterior overjet. So unless your teeth are tipped in weird directions, all right, if the teeth are straight, to have a 2.5 millimeter posterior overjet on the maxilla, the bone should be 2.5 millimeters wider on each side for a total of 5 millimeters. We don't often see people with crossbites and stuff because what's very common is to see what we call lingual inclination of the molar. So if you look at your lower molar right here, if I drew a line through the long axis of that tooth, it's tipped in towards your tongue. So that's why you don't have a crossbite, is because your lower teeth are tipping in towards the tongue. If you had proper inclination of this tooth, your lower tooth would be sitting outside of your upper tooth and you would have a crossbite on that side. Does that make sense?
Yeah, it does.
Okay, so this is one analysis I do. It's that CBCT, the UPenn CBCT analysis. And I try to see, like, is the maxilla properly wider than the mandible or not? And in your case, it was not by only a couple millimeters. For most patients that have transverse maxillary hypoplasia, it is like 8, 10 millimeters, because most people do not also have a transverse hypoplasia of the mandible. Most patients only are narrow on the top and they have a normal transverse of the mandible, but there's a lot of patients there are some patients that have both. They are narrow on the maxilla and narrow on the mandible. The other measurement that we use is something called the intermolar width. So because the teeth grow out of the jawbone, we can use the teeth as a surrogate to analyze if the jaw's growing wide enough. We try to come to where the CEJ is, and then we measure mesiolingual to mesiolingual, and you're measuring 31 millimeters across. Ideal intermolar width, this one is actually the most studied measurement because orthodontists have been using it for years. Normal intermolar width, an ideal intermolar width for an adult is 38 to 42 millimeters. Anything below 30, did I say 30? 38 to 42, is that what I said? Or did I say 30? 38 to 42 is considered ideal. Less than 32 is considered severe transverse hypoplasia. So based on this, you have a severe maxillary transverse hypoplasia. You're under 32 millimeters. But why is your skeletal analysis off? Is because you're probably narrow in the mandible too. Someone like you should have a mandible that's 5 millimeters wider than your maxilla. Your maxilla is wider than your mandible by 2, but you still have a severe transverse hypoplasia. That means you're also narrow in the mandible. Does that make sense?
Yeah.
The last measurement we do is called the piriform aperture. I'll open this up in 1 second. So the maxilla is the largest bone in the face. It's this reddish pinkish bone here. And
Hmm.
anyone who's done a consult with me, I've probably have said this exact line like a robot to you before, but it's this reddish pinkish bone here. Um, and it doesn't just dictate how wide your palate is, which is super important for tongue space in the mouth, but it also determines how wide the nasal cavity is. And so what I'm measuring is called the nasal aperture or the piriform aperture. I'm measuring how wide that skeletal opening into the nasal cavity is. For adults, we do not want to see it anything less than 23.5 millimeters across. So the way you measure someone's nasal aperture is you come to the CBCT in the coronal view. You come to before there's any nasal cavity. This is all soft tissue nose. Do not care about that. I want to see skeletal opening into the nose. And you scroll, 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 scroll until right when you see the opening into the nasal cavity on each side. And then you measure across and you're 21. And anything less than 23 and a half is considered narrow and can lead to nasal obstruction. Outside of that, obviously, there's other stuff I do. I like to scroll through the nasal cavity, look for septal deviations. Sometimes people are wide anteriorly, but as you scroll, you'll see their nasal cavity will get more narrow in the middle or posteriorly. So it's nice to just kind of scroll through and look around that way. And that is the general gist of how you analyze someone's transverse dimensions. Obviously, for corrective jaw surgery, I'm looking at other things like how forward the jaws have developed and um, orientation of the jaws and, things like that. Like, do they have canting? Do they have excessive pitch? Do they have a steep occlusal mandibular plane angle? Which, looking at your profile, you seem to have a steep occlusal plane angle. You obviously had an underbite class 3 occlusion. You can see the mandibles kind of rotated downwards because your jaw developed on this high angle slope.
Yeah, are you saying, I got a question there. When the mandible is sloped like that, is that partly genetic or is that due to
It's due to
bad?
growing up mouth breathing.
Right. So you're saying everyone should have their mandible kind of develop out horizontally for the superior ramus, or what is it? Inferior ramus rather?
Yeah, so like a normal occlusal plane angle is about 5-degree slope. So not like 0, but like 5 degrees is considered like normal. Um, and you are probably this software is not the best to do it, but I guess you're at like 15 or 20 degrees slope. The
Interesting.
normal is even more than that.
Does that usually get corrected with double jaw, or can you only push it so far usually?
Yeah,
With the
well,
counterclockwise
with corrective
rotation?
jaw surgery, I can do whatever counterclockwise rotation I need to put someone in a normal occlusal plane angle. Obviously, we're also doing that movement because it is very airway positive, right? So the more you counterclockwise rotate or drop the back of the jaw down, the more the chin auto rotates forward and with it the tongue. So it's a very important movement when doing corrective jaw surgery, particularly in people with sleep disordered breathing.
I guess what I'm asking too, though, is that like I'm what you said, let's say I'm 20 degrees, right?
Yeah.
When you do a double jaw and do that counterclockwise rotation, can you typically correct people back to normal? Or is it kind of like you can only get so far because of
Oh
this
yeah,
that
yeah, yeah. You can get people back to normal for sure.
so even the most severe cases, you can counterclockwise people back to
Yeah, I've done some big changes. Let me see if I have anything that I can show. So like this one is probably like a 10-degree correction. So this is the preoperative occlusal plane and postoperative occlusal plane. Uh,
Oh, I see what you're saying. Sorry, I was asking, okay, the occlusal plane you can always correct, but I was asking more the angle of the
mandibular plane?
ramus. Yeah.
That's a great question.
Because
You have to
were you saying
you
the
have to you
occlusal
have to
plane
do you have
at
to
5 degree
do
is normal or the mandible one?
the occlusal plane at 5 degrees is normal.
Okay.
But usually they kind of mirror each other in some way. Actually, let me stop sharing because there's some people that don't want their picture shared on
Yeah,
here.
I'll remove that.
Yeah. To do a fix of the mandibular plane angle. It's very hard to do it with BSSO. So for those cases, I'm doing something called the inverted L osteotomy. And this allows me to actually fix the plane a little bit better, and add height where you need to, because otherwise the ramus stays the same height and you're going to have that same angle at the end of the day. With an inverted L, you can actually like lengthen the ramus as you're advancing the jaw. So I'll do inverted Ls. The other thing that you can do is get implants. So, I have another case I can show. So I do custom implants in like the angle of someone's jaw. So you can just design a custom implant and fix that angle with a
Oh,
custom.
you kind of just drop it down here. That makes sense.
Yeah. So those will be the two ways. Either I'm going to do an inverted L or a custom implant. There's some other osteotomies that are, more experimental. Something called the French split, which is something that can be done, but it's more predictable to kind of stick with an inverted L or a custom implant at this point.
Is there more? I asked you this in our first interview about like mind and ease expansions versus SARPEs.
Yeah.
Is there a verdict yet with regards to AHI improvements and airway improvements? Because last time it seemed like there's just anecdotal and we couldn't like
Yeah.
slam the gavel.
Anecdotally, it's very clear that mid-face expansion is far superior to the Fort 1 level expansion that you would get with a SARPE. So anecdotally, 1000%, it's not even close. Getting three-dimensional expansion. So with a SARPE, you're gonna do a Lefort 1 cut, and you're expanding basically just the alveolar process of the maxilla, and the nasal floor will widen a little bit. So you do get some improvement in nasal breathing. With like mind or with ease, you get mid-face expansion, right? So you get the entire mid-face, the nasal cavity opens up three-dimensionally. So the volume inside the nasal cavity exponentially increases with each millimeter of expansion. Anecdotally, as someone who's done SARPEs and obviously now doesn't anymore, I do mind. It's not even close. We are publishing the data now. I don't know if you're part of the study. Are you doing the pre and post-op sleep studies with me?
No, I didn't. Because I didn't do the pre one.
Oh,
But
okay.
yeah.
So we're right now we're like doing pre and post-op sleep studies and questionnaires and stuff, and we're going to be publishing on it. And so I'll have less anecdotal and more concrete numbers soon, but I don't think it's even close. It's not going to be close.
Interesting. I can't wait to read that, honestly.
Yeah. Yeah.
All right, man. I'll let you go. I know you're really busy. I really appreciate you
Andrew,
coming
great to
on
see
again.
you.
Likewise.
Very good to see you, man. It's been a long time. I'm glad you're doing well. Looking great. Where are you living nowadays?
Mexico City still.
Nice. Enjoy.
Yeah.
All
Yeah,
right, brother.
yeah. All right. I'll send you the video when it's all edited and stuff so you can check and we'll go from there.
All right, perfect.
Okay, thanks for coming on. I appreciate it.
Of course. Bye.
Okay, bye.